Deformities are very reasonable, and I would have a lot of my old professors at Harvard that would say that you should just do posterolateral fusion in situ or just posterolateral alone without doing any interbodies very rarely. But I think that there's clearly much higher fusion rates with interbodies, and certainly for revision surgery. So the indications for interbodies are much like the indications for fusions in general. It's just what works best for certain people and certain hands, and trying to understand what you're trying to do and why. There's a whole lot of different interbody ways that you can go about this. And I think most of the time, these are going to be posteriorly instrumented. Sometimes standalone will be available, but in general, screws will be used in the back, whether minimally invasive or open. And there are a lot of different considerations for the different structures that have to be considered as we go and do these different types of procedures, and weighing the risk and benefits of each. In each person's hands, what type of access surgeon do you have? What's your experience with these different types of approaches? As far as the indications, I mean, we've gone over these. I think that in general, though, it gives a great axial support. It's a large reconstruction. And really, being able to perform bilateral releases is very helpful for certain coronal plane deformities in the adult degenerative scoliosis patient. Planning. I mean, the biggest thing with going through, especially somebody who hasn't done a lot of laterals, is really understanding and being able to look at, you can't just look at an MRI, you can't just look at the x-ray. You really have to take all these things into consideration, and really looking at these psoas muscles and getting used to seeing these things on the axial images is really the biggest consideration. And especially when you're talking about the L4-5 level. I mean, some guys say, well, 4-5 is not really a good level for lateral, but I mean, 4-5 is the most common level that has usually where the pathology is. So planning for the 4-5 level, and there's a lot of things that you can do to improve your chances of getting a cage at 4-5, and it's not that you can't get there, but you certainly need to realize when you have a high crest, and if you're really committed to wanting to do one at 4-5 with more anterior psoas muscles, you really have to think about where's the ureter and where these nerve roots really are coming out and what your experience, and you really need to weigh the risk of, that's where you're going to have increased chances for complications with this procedure. Now, of course, right or left side approach, once again, 4-5 is really going to dictate, but certainly I do like to come from the concavity. I mean, you can make a small, one incision. Sometimes you need to make 2 incisions with these types of procedures to obtain it, with one side access. I really don't like to ever flip them and go, on both sides, right and left. I think that kind of defeats the purpose. So personally speaking, I mean, I'd say 99% of the time will do my approach from whichever side that I can access 4-5 from, and then address other things in a different manner posteriorly. So great example of degenerative scoliosis. I mean, this is exactly what you're looking for a lateral case. And this is what we're talking about with the T-lift down at the bottom. And you really have to decide, though, really, the 5-1 is the biggest driver. I mean, if you've really got severe problems at 5-1, that's probably going to be more an A-lift patient, whether you're going to do that minimally invasive or posteriorly, in my opinion. So positioning pearls, just getting used to positioning these patients is extremely important. Some people do them on a Jackson table and don't really bend the table. I've seen people do that. But in general, I mean, you're going to be breaking the table on a regular table, understanding, you got to really tape the patient directly on their skin. I mean, I've never had a problem with skin tears with this, but you can't put anything underneath there, because if they roll during this procedure, it's a really big problem. And so you really don't want the anatomy to be shifting on you, especially in a more significant deformity that has rotation. So as far as, sometimes you can use positioners if you really need to. I think I've probably gone away from really doing this, I mean, often, but occasionally if you really are worried about them rolling, then you can do that. But limited flexibility, I mean, this is a good example here. I mean, these spaces are very stuck down, but you can still get pretty good releases with a lateral operation instead of just doing this all posteriorly. And as far as fluoroscopy, I mean, I used to use 2 C-arms, but it's something that you could consider, but it takes a lot of effort. It does increase the time, but it's really whatever you're comfortable with. It also depends on how skilled your x-ray techs are and whatnot. But of course, it just depends on how quickly you're transitioning from one position to the other. But now, I pretty much, I'd say 99% of the time, just do these with just 1 C-arm. Getting good x-rays and really a true AP and a true lateral is so important. So, I mean, having a great x-ray tech is absolutely mandatory to be able to do these procedures. And understanding that they need to be able to rotate the bed or change the position of the bed so they keep the C-arm beam directly vertical. And then you can obtain good orthogonal views at each individual level is incredibly important for doing these procedures. So, move the table, but don't be moving the C-arm beam, whether or not especially for the vertical component that's going up and down, which would be the lateral for x-ray in this case. So I think we've gone through most of that. I mean, you can do little things to make it easy for your tech, but getting a good tech that really knows how to do these is going to make your life a whole lot easier. As far as actually doing the procedure, you know, I do favor a direct look. I like to directly look down. I mean, I've gone from different ways from doing this with completely neuromonitoring based and not really seeing. It does take a little time to get used to and being comfortable with seeing all of those different structures. But the reality is that we're in Tiger. You're in a little bit of Tiger area anyway. We're spine surgeons, so there are other structures there that other people are more skilled at dealing with. But you really need to, I would encourage all of us to get used to seeing these things, particularly at 4-5, if you want to be able to do those more complicated cases. And I think to do them safely and safer, being able to see that is very important. So once we're dissected down, usually with Wiley veins, I mean, you know, seeing that and getting your initial starter dilator, I mean, I like to directly visualize the disc space. So I can see the lateral aspect of the disc space directly. Still stimulate when you're down there if you'd like, but when you're seeing that directly, then putting that initial dilator and K-wire in really does decreases your concern for getting a neural injury, particularly at number 4-5. So once positioned, I mean, obese patients, they're certainly, I mean, but the nice thing about a lateral rather than the ALIF is, I mean, most of the time, you know, the tissue really will fall away. So it can look pretty daunting initially, but this is a great procedure in somebody that's extremely difficult, perhaps extremely high risk for an infection, or somebody that you've seen multiple times, they really are having trouble, and there's just no way you can get around it to be able to offer them, I believe, a good solution or an alternative solution to nothing. Obviously, understanding the lumbosacral plexus is extremely important, especially at L4, L5, and understanding the anatomy of your psoas for your patient is absolutely mandatory, and getting used to being able to see the nerve roots, not just see the trigger on it. You need to be able to look directly down there and see them so that you can safely change the position of your instruments down there, and I think that is a huge thing. Also, I mean, obviously neuromonitoring, this is a mandatory, you're going to have to neuromonitor on this procedure. I mean, I think most all of us are neuromonitoring for most of our spine cases anyway, certainly for fusions, certainly cord level. But in regards to lateral, I don't think anybody would say that you can do these without neuromonitoring. And something to consider is certainly, we don't have time to go through all of these, but they're all the same. It's 4-5, it's the quad, you know, and it's the length of retraction, how long the retractor's being in there. And most of the time, if you're going to see a change, you're going to see this later on. And these are earlier on in my career. And so you think about this and, like, you know, what are the reasons why? I think length of the retractor at the disc space. You really want to be, once that retractor's open, 20 minutes has got to be, if you really can't get it done in 20 minutes, you shouldn't be doing a lateral at that level, or you really ought to consider doing something different, because that's where you're going to have the problem. And so that, combined with considering using motors, if you really know that you really want to be able to do a lateral at a certain level, I think using motor evoked potentials down there is potentially, there's some literature that's going to suggest that you're going to have a better chance of realizing a problem before you have a problem. So different cases. I mean, this is a great case for a lateral. No significant central stenosis. Most of this is going to be foraminal with, mild at most or moderate lateral recess stenosis. And to me, this is a perfect case for a lateral with a minimally invasive posteriorly indirect decompression. 2 incision, I mean, obviously it's there, but now I'd say I don't ever use the 2 incision. I think when you're first kind of starting off, it can certainly be something for comfort, but directly visualizing and seeing this is, in my opinion, significantly better. To be able to get comfortable with seeing that using 2 Wiley vein retractors, being able to ensure it, find the ureter, find the genitofemoral nerve, and really remember what those MRI images look like is going to be incredibly important to decrease your anxiety when you're going and doing these types of procedures. So just one more time, the steps here. Wiley vein retractors down to the disc space, directly looking, directly placing that dilator on the lateral aspect of the disc directly, dropping the K-wire through. I used to go more anterior 2/3. Now it's just direct, right at the midline, 50%, 50-yard line, right at the middle. Certainly, I mean, I'm a big fan of a 2-blade retractor rather than a 3-blade. This is not the time for this discussion. Dr. Tollers can give you different points on that. But I favor transosseous pins. I don't want this moving, really no matter what. And the big benefit is that then when you get a lateral, like the 3rd picture there, you can see exactly where you're about to be going. And having those pins in really does allow you to say, hey, I can put in a 22 or whatever. If you have a bigger option, a 26, you can really understand that when you know that the blades are 24 wide, anterior to posterior. And then just going through, I mean, obviously a cob, releasing, top, bottom. Curved cobs are important, shavers, and trialing until you can get the type of implant that you'd like. And I've gone back and forth between titanium and PEEK, and I think that there's good reasons for both of them. And it just depends, it really depends on the quality of the patient's bone and what you're trying to achieve. So lastly, just a few of those things with the retractor pearls. We just went over those, and I'll let Dr. Tollers talk more about that. Removing one of the pins for a buttress plating can be helpful if you're worried about a cage moving or migrating, or if you're going to stage this procedure. That's certainly something to consider. And really trying to figure out. I mean, obviously this is the device that we've been working on with Innovasis for a good bit, and there's been a lot of thoughts into it. I think that we think that it's going to be a great thing. I really think that the visibility of it, the way that the cage is designed, is going to be able to allow people to really achieve pretty much everything that they would like. So this is just getting a sneak peek of what that really looks like. But wide implants, when possible, really does help and make a difference, I do believe, as far as getting a high fusion rate, preventing the subsidence, and preventing things like what you see down there at 4.5 from happening. So I'm pretty much going to let Dr. Tollhurst come on in. We're going to save the cases for later. All right.